going to go ahead and get started with the hope and understanding that we're broadcasting. In the worst case scenario, we are recording this and everyone will receive it. So with that, this has been no less than a dramatic start with our presenter rushing from the airport owing to a late flight to get to his hotel to do his presentation. And with that, I want to welcome everyone to this installment of the Practice Perfection Web-Based Education Series. I'm Danny Bobrow, President of AIM Dental Marketing, and it is my sincere pleasure, and as I said, I'm particularly excited today, owing to the drama, to welcome to the Practice Perfection stage, Roger Price. Roger is here today to share with us a case study entitled Sleep Disorders, Another Perspective. Roger is a respiratory physiologist, integrative health consultant, and the creator of the Breathing Well orthopostural program designed to address the below-the-line issues involved in dental and sleep disorders. He serves as coach to dental professionals worldwide, teaching and training dental teams to deliver stable patient outcomes. Roger is an internationally recognized expert in the relationship between daytime dysfunction and sleep disorders. He created the concept of breathing disordered sleep, which posits that it is unlikely for one to breathe functionally while awake, having only a nighttime breathing disorder, and vice versa. He has created a system which identifies and addresses both daytime and nighttime issues, a system which can be integrated into any dental, orthodontic, or sleep practice. The so-called diseases of bruxing, sleep apnea, TMJ, and other craniofacial disorders are actually symptoms of imbalance, compensatory mechanisms to enable breathing to continue at any cost. The unique power of this system is based on the fact that it requires no practical input or time from the practice principal. It is delivered entirely by trained ancillary staff, allowing a quicker and more stable outcome by removing underlying issues which often impede treatment. Because he has so much information to impart, today is the first of 2 consecutive presentations Roger will deliver. This first session will focus on an introduction to the integrative care model and its importance, the risk-return trade-off, and iatrogenesis. Next month's session will concern itself with the how, that is, what can be done, who can do it, and how it can be achieved. By the time you've heard both presentations, you will know what Roger means by looking after the patient attached to the teeth. His protocols hold the promise of transforming both your practice and the way you view sleep dentistry. Now, as usual, today's event will run for 90 minutes. I invite you at any time to submit your questions using the question button on your screen. We will do our best to get to all your questions following Roger's presentation. If we are unable to do that, we'll be sure to follow up with you personally. You will also receive an email by next week with directions on how to apply to receive 1.5 hours of CE credit. Now, because today's presentation will be recorded and shared, we want you to just sit back, relax, and enjoy the talk, but by all means, feel free to submit any questions you may have. And finally, the AGD disclaimer. Participants are cautioned about the dangers of incorporating techniques and procedures into their practices if the course has not provided them with adequate clinical experience to allow them to perform it competently. And now, let's hear from Roger Price. Hello, Roger.
Daniel, good afternoon to you from 106 degrees in Phoenix.
Hello, from where it's very rainy in Chicago.
Well, we need a little bit of balance in life, don't we?
We do, and we got it.
So I'd like to start off by saying thank you very much to Danny for facilitating this and making this possible. I like to work on the principle of one picture is worth 1,000 words. So my first 1,000 words come to you in this cartoon, which I think speaks for itself. Equally humorous and true is what Voltaire said. And yes, medicine did used to be amusing the patient while nature cured the disease. I started my career as a pharmacist in the mid-50s. And the medicines that we made, if you took them, if you didn't take them, you got better in a week or in 7 days. We didn't have the terrible degree of side effects that one has in modern day medicines. And we were talking about iatrogenesis. Iatrogenesis is a combination Greek, Italian, Latin, Roman word, which means nothing other than this is the disease caused by your doctor. And of course, medical professionals don't want to say, I'm sorry, I made you sick. So they say, you are suffering from a iatrogenic condition. And that, of course, is very sad because when you go back to the premise of firstly do no harm, why would one prescribe medications where the list of side effects is as long as your arm and could kill a brown dog? It is then worked on, unfortunately, the principle of risk-benefit. But when you have a look and you see that in 2010, 2011, 122,000 Americans died as a result of approved procedures and correctly prescribed medication, one has to wonder, is the benefit really worth the risk? And are we looking at a very short-term benefit, like today, tonight, and tomorrow, as opposed to a risk that increases with the passage of time? And I'm focusing particularly here on children, because if we fail to identify and do something about the malfunction and dysfunction in early childhood, we are almost guaranteed to consign that child to a future of unfortunate chronic ailments. So Western medicine is based on symptoms, and a symptom is a message telling us that something is wrong. They should be listened to. Modern medicine regards symptoms as diseases and shoots the messenger before even reading the message. We've ended up as a society with a pill for every ill. And the sad thing is that if there isn't an ill for a particular pill, that will probably be created and then sold to us. Some months ago, Pfizer decided to make an investment of $50 billion into China. And when their international marketing director was interviewed on television, his justification and validation was, as China becomes more westernized, it develops the diseases of the Western world, and of course they make the drugs for those diseases. So if a pill won't work, why don't we irradiate it or bombard it or cut it out or connect it to a machine? Why don't we do everything that we can to intervene in something that we have accorded a grab bag philosophy? So who hasn't had a sore throat? Who hasn't had a runny nose? A mild cold virus? Just waking up feeling lousy? These are very common things. They're all bundled together and called the flu. And of course, if you have the flu, you have to have the flu shot. And you might be interested to know that the global flu market has grown from 10 billion in 2006 to 40 billion this year. What about if you're breathless, if you're short of breath, if your chest is tight, if you cough a bit, if you have trouble breathing? You have to have asthma. And of course, if you have asthma, you have to have a puffer. Now, what I'm going to show you next is sad. I'm going to show you something which says that asthma is regarded as a significant respiratory market opportunity. What about the child? What about the future? What about the inhaled corticosteroids interfering with body functions? No, it's a global market. It'll reach 47 billion by 2017, and it is a significant respiratory market opportunity. What about open mouth, mouth breathing, low tongue posture, crooked teeth? You've got to have braces. And braces is an industry which is growing exponentially. Look to be $3.84 billion by 2020. And the sad thing is that 8 out of every 10 children in the Western world have crooked teeth. And we will talk about that a little bit later. What about snoring? What about being tired? What about cranky, low energy, disturbed sleep? No, you've got to have OSA. And if you have OSA, you've got to have CPAP. And of course, there's an explosion in this market as well, running around about $6 billion. Nobody gets any better. Billions of dollars go down the drain, and it is short-term symptomatic intervention. Chronic disease is rising year by year, and this frightens me. I've only been living in the US for just on 2 years. I came here from Australia. And when I see that by 2030, 1 in 2 Americans will be suffering from a chronic disease, I have to throw my hands up in horror. And at the tender age of 75, turn around and say, please, we have to do something. We have to do something to stop the onslaught of these chronic illnesses, which can, in many cases, be avoided. So that is why I've titled this, It's All About the Airway. Because in truth, the reality is, it is basically all about the airway. And let's follow that thought principle through over the next hour or so. As Danny mentioned to you, this is a 2-part program. What we're going to cover today is the integrative care model, why it's important, the risk versus the benefit, the concept of iatrogenesis and the future. And next month, we're going to look at what can be done, who can do it, how it can be achieved, the detail, and quo vadis, where do we go from here? So let me ask you a question. Just because something is common doesn't mean it's natural. Crooked teeth are common, 8 out of 10 children. Ear infections are common. How many myringotomies are done? How many kids are walking around with tubes in their ears? How many rotten tonsils do you see in the course of your day? How many complaints about jaw joint tenderness? What about chronic complaints about poor sleep patterns? And of course, the inevitable obstructive sleep apnea. These things are common. They are not natural. Some things are changing, but unfortunately not quite quickly enough. There is a move away from the fall on the floor bicuspid extractions and the brackets and wires pulling the rest of the teeth back into place, the level and align to the lower incisors. These things are changing. They're changing with the advent of myofunctional dentistry, of orthotropics. Dr. John Mew, who happens to be a dear, long-time personal friend of mine, has been at the forefront of this for a long time. But if you have a look and you look at these 2 boys who are twins, and you look at their faces, pre and post, extraction versus orthotropics, there is a difference. There is no single truth. There is a wonderful saying which says, orthodontics is an art trying to be a science. And there's a lot of sense in that because there is only one orthodontic treatment that works. And that's the one that gets a stable result. And your starting point is so different because basically no 2 children have the same raft of issues. We will again come to that as the presentation goes through. So let me give you a little background just so that you know where I'm coming from. I started as a pharmacist in the mid-1950s in South Africa at Rhodes University. I came to the United States to do my postgrad in physiology, pharmacology, toxicology at Colorado, then went and did postgrad in nutrition and remedial body therapy back in South Africa. I had 2 years as an associate professor in health science and medicine at Bond University in Australia, and did my diploma in integrative medicine, Queensland University in 2008-2009. What I'm talking about is light-hearted but scientific, and it's based around 2 postulates. One is Newton's third law of motion, going back to 1642. Every action has an equal and opposite reaction. Let's bear that in mind when we start looking at dysfunction. And of course, the hoary old Bohr effect, 1904, Christian Bohr, what he said was, and please, I really want you to keep this at the forefront of your minds for the next hour. This is central. This is critical. This is fundamental to what is going on. As the pressure of carbon dioxide in arterial blood drops, so does the bond between oxygen and hemoglobin tighten. The more you overbreathe, the less CO2, the less oxygen release from hemoglobin. Think about this with snoring. Think about this with hyperventilation. Think about this with talking really fast. Those of you who exercise, think about running with your mouth open and how sometimes it is so difficult to catch your breath. Bohr from 1904 is central to breathing and sleep disorders. So we will only ever catch 4 things in our lives: viruses, bacteria, parasites, and fungi. Those are the only 4 categories of communicable diseases. Everything else is created. Okay? Whatever else we have is as a consequence of what we are doing. You do not catch bad posture. You create bad posture as a consequence of what you do. When did you ever find food in your mouth by accident? We are masters of our own nutritional destinies. We choose the way we sit, we choose the chairs, we choose the positions, we choose our occupations, then we blame our occupations. And of course, we choose our emotions. Those two could equally be laughing at each other as yelling at each other. And when you start to look at the consequences of overbreathing, hyperventilation, open mouth breathing, stress, cortisol response, living life in a state of cortisol drive, of sympathetic dominance, you'll see why there is a link between what we are doing and the way we feel. All of this affects the way we breathe and how we sleep. And please remember that second only to heartbeat, we breathe more times a day than any other function in the human body. We should not be breathing more than 13 to 14,000 breaths a day. Most people breathe at least double that and even more. And this is commonly known as overbreathing or hyperventilation. And again, you will hear more about this as we move along. So let's do the math. If you have a look at normal, high rate, low volume, low rate, high volume, increased dead space, it all comes out that we breathe on average, minute volume, 6 liters of air per minute. That is a meta-analysis that comes from many, many research papers going back many, many decades. Bear in mind, 6 liters of air per minute is minute volume. Have a look at this. Here is our norm of 6 liters per minute. That is accepted, or was accepted, as being the correct level of breathing. Now look at the 10 years between 1929 and 1939, which incorporated the war years, where food was not plentiful and people did it hard. Their breathing rate dropped. The minute volume dropped from 4.6 to 5.3. Magically in 1950, 53, 54, 55, when McDonald's and Burger King and the fast food restaurants with the highly processed foods, with the sugar and the salt and the refined carbohydrates, our breathing rate, our minute ventilation doubled. It jumped to 12 liters per minute. And it now sits there as the new normal. And if you have a look at statistics in sleep studies, in hospitals, in medical practice, it is now accepted that 12 liters of air per minute is normal. It is common. It's not normal. It's not natural. Doing double what we're meant to be doing, just as a consequence of Newton's third law, has to have compensatory problems. And pardon the English version of I can never get my mouth around compensatory. It compensates. Okay, it compensates. All right. So here we go.
You did it right both times.
Hyperventilation is all but ignored. The statistics I've heard say that 60% of admissions to A&E list hyperventilation as a symptom. People are hyperventilating when they come out of the ambulance or when they come into the emergency room. By the next morning, they're not hyperventilating anymore. They're in a warm bed, pretty nurses around, they've been stabilized, and the hyperventilation goes. So let's have a look and see what actually happens when you hyperventilate. The very first thing you do is you drop your carbon dioxide levels. Okay? That is why the old-fashioned cure for the panic attack was to breathe in and out of a paper bag, so you could rapidly re-inhale the carbon dioxide that you've lost through panicky breathing. The moment you lose your carbon dioxide pressure in the alveoli and the lungs, you have disrupted biochemistry. The body cannot function in biochemical balance if its prime buffer component, which is carbon dioxide, is below optimal. So we then have a relationship between disrupted biochemistry and sleep apnea, bronchospasm, asthma, allergies, anxiety, panic attacks. There is a link. There is an apnea hyperventilation link. And if you look at the word apnea, no breath, the Greek word, there is a direct link between hyperventilation and central sleep apnea. There's a direct link between overbreathing and asthma and hypertension and digestive disorders and nighttime pee journeys to the bathroom and bedwetting in children. I'll expand on this as it goes along. But for this, at this moment in time, just keep in the back of your mind that there is a link between overbreathing and chronic conditions. And just remember that overbreathing is now sanctioned as being normal at 12 liters of air per minute. Right, that is not normal. It's common, but that is not natural. It is not natural to sleep in that position. How many of you, and I want you to be very candid about this, how many of you during the day find that you have stopped breathing? You can put your virtual hands up. You're cutting a crown, you're working on a patient, you suddenly find you have stopped breathing. How many times do parents report that their children stop breathing when engrossed in something interesting? The question has to be, why does this happen? Why should somebody stop breathing during the day or at night in the absence of a physical obstruction? Think it through for the moment. You're erect, you're working, you're talking, you're functioning, you stop breathing. Nothing's fallen into your throat, your mandible hasn't slid backwards and occluded the airway, you have just stopped breathing. Why? It is a simple biochemical response. And now we're going back into the classroom for a while, and we're going to revisit some of the biochemistry and physiology that you would have done in the beginning of your studies, and probably not remembered because it really isn't that valid, or it hasn't been that valid to dentistry up until the time that dentistry became involved in sleep. So let's pursue this for a while and have a look at it. Normal pH is around about 7 on your scale of 0 to 14, and that is maintained using buffers. And your buffers are bicarbonate or carbonic acid. Both of them, as you see, require the CO2 molecule as the base. Overbreathing disrupts this bicarbonate carbonic acid balance, causing the pH to shift either side of its optimal values. This causes a rapid reduction in oxygen flow to the brain and causes the brain to go into correction mode. This PET scan shows that 20 seconds of overbreathing, hyperventilation, yelling, shouting, screaming, frustration, emotion, coughing, sneezing, anything that you do consistently for more than 20 seconds where you are exhaling more than normal will reduce the oxygen content of your brain by 40%. What about Newton's third law? What about this action having an equal and opposite reaction? The overbreathing will be addressed by the reaction of underbreathing or breath holding. How does this happen? Well, you can have a physical blockage, which prevents air from moving in and out of the lungs. We know this is the case with the big truck drivers, with the retired NFL players, with people who are obese. We know that in certain cases there is an excess of palatal tissue. You have a large tongue, you have a large uvula. People very often when they're that size tend to sleep supine, and gravity will drag these tissues back into the throat and will occlude breathing. That is what CPAP was designed to do. It was developed in Australia by Colin, his name will come to me in a moment. And he took a vacuum cleaner and he took a snorkel mask. Colin Sullivan was his name. And he connected the snorkel mask to the exhaust of the vacuum cleaner. And he put it over the face of a man who was just about to go and have a tracheostomy. He could not breathe. Magically, the air splint lifted the palate and the uvula, and he could breathe again. That was the start of CPAP, and it is still very valid for that type of condition. The second thing that can happen is there is an inflammation or a congestive condition brought about by hyperventilation or overbreathing that narrows the airway. Let's talk about that. If we're designed to move 6 liters of air per minute, and we start forcing in 12 liters of air per minute, we are going to get a local systemic reaction. We're going to get an inflammation, we're going to get congestion, and those delicate mucosal tissues that form the back of the throat and down the posterior wall of the throat going towards the esophagus, to the trachea, to the larynx, those tissues can become inflamed and congested. And I've just written a new article which is titled Airway Collapse, Fact or Fantasy. And in that we look at why people have trouble breathing. And we question, is it a collapse of the airway, or is it a narrowing of the airway largely due to localized inflammation because of dysfunctional breathing? And you might find that quite an interesting article to read. It's ruffled a few feathers, but hey, I'm not afraid of ruffling feathers anymore. I just do it very nicely. And because I have an accent, I can ruffle feathers without too much concern. I never said that. Okay. Thirdly, we could have a structural issue where the mandible will fall back and block the airway. And if you add that to the other two, we have the perfect storm. And finally, there could be a neurological, neuromuscular, or biochemical reason why the mechanics of breathing ceases. I know it is very, very common, and you'll see I will show actual written versions of what I'm saying shortly, for doctors to say that central sleep apnea is a failure of a message to breathe to move from the brain to the muscles of breathing.
Roger.
Yes, Danny.
I'm going to ask you to take a breath yourself momentarily. We have some people that are having trouble hearing the audio. Virginia has been on with technical support for the last 20 minutes.
Right.
We're going to make a brief attempt here to see if we can get those other people on. And so you may hear a brief hold, and then in any case, we'll come right back to the phone and you can continue presentation.
Do I have time to get a bottle of water?
You absolutely do.
Okay,
Right,
I'll be back in a second.
All right. One moment, everyone. Hello. Well, that was worth trying. Looks like we'll see. I should have heard that should have gotten an affirmative response, but we'll see. I'm going to invite everybody else. If you've now those of you who are not able to hear, anyone who is now able to hear, please let us know. In any case, as I've already shared via chat, if you're not hearing it, we are recording this and you will receive the archive. Are you back, Roger? Roger's not back, but he will be.
Okay, my whistle is wet.
Good. Well, please proceed, Roger.
Are we okay?
We're good.
All righty. So the neurological conditions are generally rare. You've got Guillain-Barré, you've got myasthenia gravis, you've got Lambert-Eaton. It's not something that we come into contact with regularly. That's usually reserved for the neurologists and the neurophysicians. Neuromuscular conditions like Lou Gehrig dystrophy are also very common, very uncommon as far as our practice is concerned. The most common by far are the biochemical reactions brought about by overbreathing, mouth breathing, and hyperventilation. And I'm now going to take you through the biochemistry of apnea. And at the end of this, I will give you 5 published clinical trials which all validate what it is I'm going to tell you. The fact that these trials have been done and published doesn't mean that they are widely disseminated. And I leave it to you to wonder why that happens to be the case. So that is the ubiquitous carbon dioxide molecule. There it is, 1 carbon, 2 oxygens. And in order to create the oxygen hemoglobin bond, we take the air entering the lungs, which is between 20 and 21% of oxygen, and that is 4 times the body's requirement, because the body requires just 5% of oxygen for it to function optimally. And for oxygen to bond onto the heme ions in the blood pH needs to be at 7.45. Not my fault, I didn't do it. Don't ask me why, that is just a fact. It's usually not a problem, as the body normally functions in a mildly alkaline mode anyway. So provided we're breathing, and we're breathing in 20-21% of oxygen, and provided that the pH of the blood is buffered to 7.45, you will find that 4 oxygens will bond onto the 4 heme ions, and you will end up with a saturated molecule of oxyhemoglobin. That is what happens to the hemoglobin molecule. We then want to release that from the blood. So for the oxygen to be released, the pH has to shift to 7.35. It is purely a chemical reaction. It is a bond at 7.45. It is a release at 7.35. And that pH shift from 7.45 to 7.35 is controlled by carbonic acid. And if you don't have sufficient carbon dioxide molecules in the alveoli so that they can cross into arterial blood, you do not get the shift to 7.35. So we need a pressure of 38 to 45 millimeters mercury of carbon dioxide in the alveoli, and that is known as the end tidal CO2 pressure, EtCO2. Should this pressure drop below 35, the oxygen has extreme difficulty breaking away from the hemoglobin as the CO2 levels drop. And what you end up with is a saturated molecule of oxyhemoglobin that is not able to release the oxygen to the cells because the pH has not shifted. The consequence of that is that we have these chains of molecules saturated with oxygen, almost like carriages on a train, driving around the body the entire night, and you sleep for 9 hours and you wake up exhausted in the morning. You wake up exhausted not because you didn't sleep, but because you were not able to release the oxygen from the hemoglobin. Your SATs are fine. Your pulse ox is going to tell you you're running 97, 98, 99% oxygen saturation. That is fully understandable. These are saturated with oxygen, and that is not the key metric. The metric is how much of that oxygen is free to get into your brain cells and the rest of the cells in your body. So let's look and see what functional breathing is. What I have here is a diagram showing your CO2 tanks and your oxygen tanks with your indicators, your gauges. Functional breathing at rest is 8 to 10 breaths per minute, 4 to 5 liters of air per minute, marginally less than the 6 liters minute volume which is averaged out during an active life. Functional breathing is in and out through the nose at all times, absolutely not through the mouth. It is driven by the diaphragm, not by the upper chest. Functional breathing is silent. If you can hear somebody breathe, you can bet your bottom dollar there is something wrong with them. Functional breathing is silent. This results in optimal end-tidal CO2 levels, as we see here, of 38 to 45, and of course, optimal oxygen pressure of 75 to 100, which gives you full oxygenation of your cells. This is functional and balanced breathing. Snoring or mouth breathing is a whole different story. The minute volume increases, and as the minute volume increases, obviously your end-tidal CO2 is going to drop. And it drops to anywhere between 28 and 30 millimeters mercury. The pH fails to reach the 7.35, and of course, the supply of oxygen to the brain and other cells drops. You're functioning with empty tanks. Hypoxia develops, and of course, a whole chain of events takes place where the brain has to say, I have a problem, ding, give me an idea as to what I can do. And that ding comes from a little sensor in the base of the brain stem, in the medulla. And what the brain says is, I urgently need to produce a carbonic acid buffer so I can shift the pH and I can release the oxygen from the hemoglobin to counter the hypoxia. The tank is nearly empty. It's got to be topped up stat. You can see it hovering around the bottom. It's nearly empty. Immediate action is required to release the oxygen. So what do? We tell breathing to stop. Instead of that message from the brain to the diaphragm going off into cyberspace somewhere for some inexplicable reason, it is in fact a definitive message from the brain to the, something has gone click. Danny, are we still live?
We are. Why do you wonder?
Okay, I just heard a click, click in my headphones, which sounded to me as though something had dropped out. Okay, let's go back to where we were.
Sure thing.
All right, good. So we'll just go back there. So we get the halt, and we get this definitive message from the brain to the diaphragm, stop breathing. Well, gee, that's what happens when you stop breathing. Optimal pH is restored, End-tidal CO2 fills up the tanks. It starts to rise. The pH shifts. The oxygen pressure increases. And the crisis is temporarily averted because the next breath after an apnea is a snort or a gobble or a gasp or a huff and a puff. And we then drop the EtCO2 again. The pH again shifts. The oxygen flow is again restricted. And the vicious cycle repeats itself. I hope that this really is making sense because it is not complicated. It is a very simple concept of action and reaction. So now comes the million-dollar question. What causes disrupted biochemistry? So you can go 50-50, you can phone a friend, you can ask the audience, you can do whatever you like. Is it mess, is it chess, what is it? Okay, I'm being horribly facetious here. We know what it is. It is stress. Stress is the cause of dysfunctional breathing. And for a very simple reason. Stress initiates fight or flight. The moment you go into fight or flight, your breathing pattern changes. Lots of other physiological and biochemical changes take place. That is a lecture in its own right about what happens with stress, with sympathetic dominance, with a lack of parasympathetic balance, with overproduction of cortisol. That is another issue. But for the moment, just accept the fact that if you are stressed, your breathing pattern is going to change. And if we do nothing to address our stress, we will continue to overbreathe and perpetuate the problem. This is not rocket science. This is very basic and very simple. So there are hundreds of different kinds of stress. And what I've done to try and simplify the whole process is to divide them into three groups. And the first group is functional stress. The second is ingestional. The third is emotional. Functional stress is basically, what do we do? Are we in pain? How do we sit? How do we stand? How do we sleep? How do we talk? What is our posture like? Our head posture, neck posture, body posture. These are the things which cause us stress because we are compensating all the time. The next lot of stressors are what we put into, onto, or around our bodies. What do we rub on our skins? Those of us with hair, Danny, what do we wash our hair in? What about all of these things, these onslaughts from outside, which are stressing our bodies and causing us to compensate? Such a high percentage of the food that we eat today is not recognized by the body as food. It's modified, it's played around with, it's messed around with, it's processed, it's all kinds of things are done to it where the body says, I don't recognize this as food. Get out of here. Okay. That changes our breathing pattern. And of course, the third one is not what we're eating. It's what's eating us. How do we react to the challenges of living? How do we react to being single, to not being single, to having kids, to not having kids? It's tough. Life is tough. There, believe me, in the 21st century, there are challenges that we never had when I was a kid. I can promise you that. And where do you start? There you are, you're in the swamp. You're up to your ass in crocodiles. It's very difficult to remember that your first priority was to drain the swamp. Well, managing stress kind of takes away one of those alligators. And once you've pulled away the sump plug and the waters recede, suddenly those stressors are not that important anymore. So we want to address the stress. We want to address that sympathetic dominance, that cortisol drive in which so many people spend their lives. And that keeps you in a permanent state of fight or flight, making it very difficult to relax or unwind or sleep. How do you sleep when your mind is looking for the next danger that's about to attack you? even though that danger is in fact not valid. The danger is no longer a saber-toothed tiger. It's not being able to find a parking spot in the shopping mall. So provided we keep ourselves from going into parasympathetic recovery, which is way down at the bottom of the line, we are going to be cortisol driven for the majority of our lives, and therein lies the cause of many, many, many diseases. So let's have a look at what we have available to us. Standard treatment for blockage, simple. Apply an air splint using PAP. Standard treatment for a wobbly jaw, simple. Bring it forward, lock it in place, tap it, tip it, lock it, Moses it, do whatever you like to it, but keep it stable. What do we do for disrupted biochemistry? What is the standard treatment for disrupted biochemistry in the sleep industry today? Well, why don't we try low PAP, BiPAP, EPAP, MyPAP, your PAP, Provent, ASV, anything that we can throw at it, because essentially it is not understood. The medical profession, by and large, does not accept the fact that carbon dioxide and the Bohr effect have a very, very major impact on sleep disorders. Why would you try to treat a biochemical issue with devices designed to remove obstructions? That is the question. Now, those of you who are into sleep know that your treatment of choice, and I'd love to know whose choice, in fact, I think I do know whose choice. The treatment of choice for central sleep apnea is now ASV, adaptive servo ventilation. And that, to me, is actually a very, very interesting thing. Is it perhaps not that the application of some of these works by default? Do you think it's not possible that because you have a mask over your face, your breathing rate changes, your carbon dioxide levels remain higher, you maintain the arterial pressure, you prevent the loss of the CO2, and you keep the buffer closer to the 7.3545 so that you don't develop the apneic events? Is it not possible that the way these things are purported to work are in fact by default? And given the very poor compliance rate of having to wear a machine, I think there could be other ways that we could do this with equal success. My belief is that generally the definitions are vague and ambiguous. There are no firm or fixed standards by which a diagnosis can be accurately made. The parameters are arbitrary, they're variable and non-scientific. I mean, what's an apnea? What's an AHI? What's a hypopnea? What is a valid metric? 5 to 15, that's 300% variation. And if you take into consideration that the hypopnea, which is part of that calculation, is indefined, it can be anything depending on the lab that you use, anything from 30% to 60% of an apnea. So it is a very wobbly, woofy, inaccurate type of situation. The determinations are often made in a position in which gravity encourages migration of the tongue and the soft palate towards the throat. Many sleep studies are done with people supine, where normally they don't sleep supine, they sleep on their sides. So when you look at Maslow's law of the instrument, it says, if all that you have is a hammer, everything looks like a nail. If all you have is something to detect an apnea, when you're supine, everything happens to be OSA. So let's have a look at the definitions of sleep-disordered breathing. Have a look at that one. This is the National Center for Sleep Disorders Research. It describes a group of disorders characterized by abnormalities of respiratory pattern, pauses in breathing, or the quantity of ventilation during sleep. Is that very scientific? Does that actually tell anybody anything? What about Medicine Net? a condition characterized by repeated episodes of underbreathing and not breathing during sleep. A significant proportion of adults are thought to experience sleep-disordered breathing. Friends, you go to these conferences. How many times does the word sleep-disordered breathing, sleep-disordered breathing, sleep-disordered breathing come in? SDB, SDB. In fact, it's almost like a punctuation point. It is thrown about arbitrarily with very little understanding of what sleep-disordered breathing really is. And it's very difficult to find out what it is if these are the definitions. It is a wide spectrum of sleep-related breathing abnormalities. That's pretty broad, isn't it? Related to increased upper airway resistance, including snoring, UARS, and obstructive sleep apnea, OSAHS. Many clinicians regard SDB as a spectrum of diseases. That's not very helpful. These are at best vague, or at worst guilty of using pseudoscientific jargon to disguise the fact that nobody really knows what's going on with central sleep apnea. Let's look at the definitions of CSA. This one from Mayo is a classic. It's a disorder in which your breathing repeatedly stops and starts during sleep. Central sleep apnea occurs because your brain doesn't send proper signals to the muscles that control your breathing. Bad brain. Brain's gone on holiday. Where does the brain send the signals then? Let's carry on further. This condition is different from OSA, in which you can't breathe normally because of obstruction. CSA is less common than OSA. No, it's not. It's a lot more common. It's just not identified. It may occur as a result of other conditions such as heart failure and stroke, sleeping at high altitudes. Watch. Treatments for central sleep apnea may involve treating existing conditions using a device to assist breathing or using supplemental oxygen. They don't talk about supplemental CO2, and I have 5 clinical trials showing that that is regarded as the cure. This occurs when the brain does not send the signal to breathe to the muscles of breathing. This is a problem in the drive to breathe, or the patient does not appear to make any breathing movements. This is most commonly seen in patients with heart failure. That is a load of nonsense. Respiratory effort and resulting breathing is periodically compromised due to a complex combination of changes. ResMed, it's a form of sleep-disordered breathing. So CSA is a form of SDB caused by the temporary absence of a signal from the brain's respiratory center. Let's confirm this. Very smart guy. Very nice man, Dr. Peter Gay. And you can see he has more degrees than the thermometer. He is very highly respected in his field. And in an interview with Res Medica Clinical Newsletter in 2007, this is what he wrote. It's quite long. I won't give you the full detail. It's there if you want to look at it. It's a combination of factors which involves the brain, the heart, and the lungs. Okay? A characteristic feature of CSA is hyperventilation. Okay? It drives hypocapnia to a consequence, and in heart failure there's increased ventilation, yada, 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 yada. This is the next important thing. In healthy individuals, CO2 levels normally rise during sleep. If we go to sleep with a low CO2 level below a certain value, which is the apnea threshold, breathing will be inhibited and reduce or even stop until the CO2 rises when breathing resumes. He does not say breathing will stop because the message to breathe from the brain gets lost somewhere along the line. This is very important to understand about CSA. These are the 5 clinical papers I told you about. This is the Journal of Applied Physiology, Effects of Inhaled CO2 and Added Dead Space on Idiopathic Central Sleep Apnea. It's very small, and I've just highlighted the conclusion. Because raising PaCO2 through 2 different means virtually eliminated CSA, we conclude that central apneas occur during sleep in ICSA are due to reductions in the arterial pressure of CO2 below the apnea threshold. Christian Bohr, 1904. If the pressure of carbon dioxide in arterial blood drops, the flow of oxygen from the blood reduces. Trial 1 of 5. Respiratory and critical care medicine. Treatment of refractory sleep apnea with supplemental CO2. There we go. Abstract conclusion. We report the successful treatment of this patient's CSA syndrome with the use of supplemental CO2 therapy. Harvard University. Low concentration CO2 is an effective adjunct to positive airway pressure in the treatment of refractory mixed central and obstructive sleep disordered breathing. Conclusion. Low concentrations of CO2 added to conventional PAP effectively controlled the treatment-resistant mixed apneas. Brompton Hospital in London, my old stomping ground. The effect of CO2 inhalation on central sleep apnea and arousals from sleep. Conclusion. CO2 inhalation reverses CSA, but not arousals from sleep. Our findings highlight the need for treatment options that reduce both respiratory events and decrease arousals with associated SMA sequelae. Okay. This is an Irish hospital and this is a Danish hospital. Normalization of CO2 by means of a novel breathing mask. Note, CPAP, mask, work by default. These guys put on a mask in which they pumped CO2 in 2 hours a day for 4 weeks. They changed the normal resting CO2 and acid-base levels, and the symptoms were reduced. This was using a mask for 2 hours a day. So everybody talks about sleep-disordered breathing. The focus is on what sleep does to breathing and what kinds of devices, machines, drugs, and other interventions can be created. If those 5 clinical trials are talking about putting supplemental CO2 back into the lungs, why don't we concentrate on teaching people how not to lose it in the first place? And that then brings me to my concept of breathing disordered sleep. Is it not possible that the 2/3 of our lives that we spend subject to stress, poor seated position, poor breathing, too much talking, wrong types of foods, the emotions, if we start to look at these things and start to manage them during the day and teach people how to sleep with their mouths closed, do you not think we have a possibility of getting a better outcome? So let's look at traditional medicine. Symptoms and causes, identify the symptom, and prescribe something. That is the current system. Some cases it works, but unless you address the causes, the problem returns. Let's go bush. Let's go viral. Let's talk about complementary and alternative processes, looking at the influences. Why don't we then combine the two? And why don't we start to look at the patient attached to the symptoms as well as the symptoms attached to the patient, and adopt the integrative approach, which has to be the model of the future. If we don't do that, we will have financial Armageddon. The medical system, the health system, was not designed for people to live to the age of 90, having had 2 hip replacements, 2 knees, a quad valve bypass, and being on dialysis. These things cost hundreds of billions of dollars. What we have is a Ponzi scheme where governments are propping up their disease management businesses so that they can remain in power. None of this has anything to do with health. Now, dear Southwest Airlines allowed me to bring my soapbox with me. Right, what can we do about this? On the one hand, we have valid proven scientific research that substantiates the fact that these ailments are created, not caught. And if we address them correctly, they can be reversed rather than treated. Why don't we do this? We have this brick wall of dogma, this resistance and conviction that the only solution is a randomized controlled trial. The only solution is evidence-based medicine, without asking on whose evidence this is based. Peer review. If you have something that is fundamentally wrong, and that is reviewed by peers who have exactly the same philosophy and concept, is there much value in that peer review? And of course, what is the gold standard? Cynically, unfortunately, the golden rule is that he who has the gold usually makes the rule. And what is best practice? Best practice is not necessarily that which gets the best results. Best practice is what most people are doing. And most people in the medical and the dental world have one fear, and the fear is litigation. Therefore, best practice is a cover your backside type approach where we will do anything and everything to protect ourselves. And I really want you to take this next quote and think about it and remember it. This was a very clever man. His name was John Maynard Keynes. He's a British economist. He said, "It is more acceptable to fail conventionally than it is to succeed unconventionally." And if everybody is, chucking 4x-cuspids on the floor and slipping whizzies and using brackets and wires, that is best practice because everybody is doing it. If everybody is prescribing statins, if everybody is prescribing Xanax, if everybody is prescribing these things, it becomes best practice, but is not necessarily the optimal way to handle things. So education is the key. And I've created an education principle here based around the iceberg. Only 10% of the iceberg is usually visible. The real danger lurks below the surface. And there was that 9% below the surface that sank the Titanic. It wasn't the 10% at the top. So Berg education is based on regarding symptoms as being 10% of the entire picture. And the seemingly unrelated exacerbatory factors below the surface really are things that should be taken into consideration. So I'd like you to meet my Berg family. And the first one is the tooth Berg. And if you have a look at the tooth Berg, you will see above the line is what most general dentists, orthodontists, those doing orthodontics, focus on. The position, the orientation, the aesthetics, keeping the teeth and the gums nice and clean and controlling the periodontic issues. What about below the surface? What about the body posture? What about the tongue posture? What about nutrition, breathing mechanics, sleep, dynamics, head posture? What about the disrupted biochemistry, the learned behavior, the emotions, the heredity, the facial muscle imbalance, the sleep? Is it not possible that these things should be addressed side by side with the 10% visible symptoms? What about the sleep Berg? How many billions of dollars are spent above the line on CPAP machines, on snoring devices, on PSGs, on home studies, on ASV, on your PAP, my PAP, his PAP, BPAP, their PAP, their PAP? What about looking at the overbreathing? What about looking at the mouth breathing, the daytime breath hold, the stress, the tissue obstruction, the overweight? I could go on and on and on. Can you see the relationship between the below the surface etiology and the above the surface symptoms? What about our old friend the jaw Berg? Why do people have TMD? Why does the temporomandibular joint become inflamed? It is compensatory. It is Newton's third law. It is a reaction as a consequence of an action. And just look at these below-the-line conditions that can cause an equal and opposite reaction up in that delicate joint in the head. And of course, the Stressberg. Stresses are basically regarded as above the line. These things below the line are what produce, add to, aggravate, and exacerbate stress. So how do we solve the problem? The startling fact is that it is estimated that 9 out of 10 people with breathing and sleep disorders are not even aware that anything is wrong. And they seldom make the connection that it is what they are doing that is actually causing the problem. When I have patients coming in and I talk about breathing training, they look at me like I've stepped out of a spaceship. They say, why should I have to be taught how to breathe? Everybody knows how to breathe. Well, everybody can play soccer as well. To play soccer, all you need is a foot and a ball. And all you have to do is stand behind the ball, lift your foot, and kick the ball. That's playing soccer. So why do we need a coach? The coach is to teach us where to kick the ball, how to kick the ball, where to place the ball, how to time it. The same applies to breathing. Less than 10% of the population knows how to breathe functionally. It is just a common side effect of 21st century living, of food, of occupation, of stress, of electromagnetic radiation. All the things that constitute 21st century living are in fact the things that are causing problems. Many people have heard horror stories from friends and family about the nightmare sleep study, the CPAP machine, the lump of plastic and metal in the mouth. They simply will not agree to be tested. They are what I very fondly and carefully call Egyptians. They're in denial. That's a terrible one, I think. That's a very bad one. Shockingly bad one.
You haven't been
Okay.
You've been hanging around me too long.
So, don't tell me, show me. We're living in a world of visualization. Everything is visible. It's iPads, it's iPods, it's television, it's monitors, it's iPhones, it's Androids. Seeing is believing. People want to know by seeing. Not many people are able to visualize what we are trying to explain because their frame of reference differs from ours. Seeing is believing as far as they're concerned. And if we can show them what we're talking about, it becomes easier for them to understand what we're saying. This visual world has to be employed in what we're doing if we want to get patient compliance. We must utilize every possible weapon in our armory, the range of tools at our disposal to explain what is happening. And of course, one of the most incredible tools of all is the ICAT. Cone beam just makes our lives so much easier. Somebody who doesn't have an idea where their larynx is, their pharynx is, where their tongue is, where it should be, where the tonsils are, where the adenoids are, we can suddenly show them live and in glorious technicolor what it is that we're talking about. You show them a compromised airway, they can understand how bringing the jaw forward or getting the tongue out of the way can actually have a beneficial effect. Show them that sleep can be efficient as well as being inefficient. This is a very simple philosophy. This is cardiopulmonary coupling, CPC. It's a simple little device. It's got 2 electrodes, one on the chest, one on the lung, a single wire. It is not a sleep study. This does not get us into trouble doing sleep studies where that is the purview of physicians. This is purely sleep efficiency. Inefficient sleep, efficient sleep. Show them breathing. Show them what is efficient breathing and show them what is inefficient breathing. And this is measuring the end-tidal carbon dioxide levels relative to that line that I told you about, which is the 35 to 45 millimeter mercury pressure of end-tidal CO2. This person is not reaching the line at all. This person is breathing efficiently, and they are keeping themselves in a state of biochemical balance. Show them what they're like when they're sleeping. Put this little app, it costs $4. It's called Snore Lab. You put it on your phone and you put it next to your bed at night, and it tells you your quiet periods and your noisy periods. And in fact, it has audio, so you can hear what you're doing while in bed, well, most of the time anyway. Show them how they're actually sitting or standing. We look at midline, we look at lateral. We actually show people how it is that they're standing is having an effect on the way they feel. And I must admit, my most valued teacher, somebody to whom I would be ever grateful, was a wonderful man, James Weldon Johnson. He was born 1871. He died in 1938, and he was probably one of the most prescient amateur anatomists that lived. He achieved many things in his life, but his crowning anatomical achievement was the creation of the song Dem Bones. Because the reality is, the foot bone is connected to the leg bone, is connected to the hip bone, and it is patently ridiculous to expect to address multifactorial issues by focusing on one single segment. I take my hat off to him, and I thank him. So this is the first of the two-part series. I hope that I have covered for you in some degree the integrative care model, why it's important, the risks versus the benefits, the concept of iatrogenesis, and the future. And next month, if I'm lucky enough to have you join me then, we're going to see what we can do about it, who can do it, how it can be achieved, the detail, and where to from here. Thank you.
Thank you, Roger. And I think you can rest assured that anyone that attended this presentation will be hanging on and anxious to hear what you have to present next month. I know I can't wait. Let's jump into some questions in the few minutes we have remaining. We did get a number of questions. As you know, we had some trouble connecting with the audio. I had sent repeated messages to attendees assuring them that we are recording this and they will receive their links to the archive within the week, which will give them plenty of time to bone up and prepare for part 2. Meantime,
well, Danny, what I did was most of the slides contain more or less written what I was saying. So
I think that explains why a lot of people, I was receiving chats and emails, even those who weren't hearing were staying on. And this will just, I think, flesh it out so much more for them. But no, I could see and hear that, fortunately.
Okay, excellent. So let's do it.
Okay. First question is, what led you to your conclusions and predictions?
The fact that it is more acceptable to fail conventionally than it is to succeed unconventionally. After spending more than 50 years in the medical field, I had to wonder why would somebody do nothing other than intervene, diagnose, prescribe, and continue to give repeat prescriptions? To me, it does not make sense. So I've spent the last 20 years devising a system, a simple system to try and get the message across. Hey guys, let's look at why you have a headache. Let's not say to you take 2 blue pills, and if you still have a headache, take 3 green pills. Let's look and see you've got a machete dug in the back of your skull. Let's pull the machete out, sew you up, and you're not going to need pills. And this is very much like what we have is this wonderful fleet of intensive care ambulances at the base of the cliff. And as people are falling off the cliff, there is an intensive care ambulance waiting to take them to hospital. I want to build a fence around the top of the cliff, and the ambulances can all go home.
Yeah, but then who's going to pay for all the ambulances, right?
Cynical thing.
Yeah. Well, it's what you, just to paraphrase, good health makes sense, but it doesn't make dollars.
Exactly.
Unfortunately. Very, very sad, but true. And, well, the good news is people are realizing this, are waking up to it.
Danny, I believe that we are very, very close to a tipping point. I believe that if we don't do something within the next decade, this country, Australia, South Africa, the UK, will be bankrupt. The medical bills, the medical costs will bankrupt us because we simply cannot continue to support the tens of millions of people in their 80s and 90s with these horribly expensive, chronically interventive type processes. We can't afford it.
That's right. It's economics is what it is, and it's not a question of if, but when. I believe, don't quote me on this, but I believe that the studies show that when a country's health care bill exceeds, I think, 16 or 17% of its GDP, they can't sustain employment any longer, and that's the tipping point financially. And this country has a way of doing the right thing eventually. I hope and pray that they'll do the right thing in this case.
But the 16 and 17% is being masked by printing more money.
Correct.
So keeping the percentage of GDP below that level by changing what GDP is.
That's right. But that's a Ponzi scheme that's going to also,
that'll make Madoff look like he's playing in a child's sandpit.
That's right. That's right. All right, next question is there supporting evidence for your assertions and comment?
Yes, there is.
I'm certain.
And the supporting evidence does not have to be double-blinded, randomized, controlled trials, peer-reviewed, written up in the Lancet. Because there are some things that you just cannot double-blind or randomize. And I'm afraid to point the bone at the medical community for having very, very severe double standards. Let me take you back to thalidomide. People will remember that thalidomide came on the market in the 60s. It was the wonder drug. It was FDA approved. It was there to fix morning sickness. Within a couple of years, there were hundreds of children born with limb deformities. Thalidomide was taken off the market immediately. Was another trial done? Double-blinded, randomized, controlled trial, was another trial done to prove that thalidomide caused birth defects? The answer is no. The medical community was prepared to take observation and anecdotal evidence as valid enough to pull the drug off the market. If they can take observation and anecdotal evidence for that and many other things, why can they not take the evidence that we have, all of us who have had these wonderful results in an unconventional way, and the stuff, those trials that I showed you, those 5, have been buried. You need an excavator to be able to find them. It took me months to dig them out because nobody wants them visible. Oh, I get passionate about this.
Well, good thing Southwest lets you take your soapbox with you.
Yes.
As you said. Is there really something that can be done to reverse the trend, looking into the symptoms, that is, instead of the causal events?
Absolutely. Now, I want all of the dentists who are listening to do something for yourselves tomorrow. Next patient you have in a chair, when you are finished looking inside the mouth, the teeth attached to the person, take a minute or two to have a look at the person attached to the teeth. See how they're lying in your chair. See how they're breathing. Are they breathing from the chest or from the diaphragm? Is their lower lip dry? Are there bags under their eyes? Do they sigh? Do they give you evidence of mouth breathing in gingival issues? Do they complain about a dry mouth? Just do that with a couple of patients and suddenly you will say, well, I can see things that I haven't seen before. Just because you're looking at the person attached to the teeth rather than the teeth attached to the person. Yes, we can do it.
And finally, what needs to be done now to bring about these changes?
Nothing other than a single word, and that is education. We need to talk to everybody. We need to bring the public into our offices, 5 at a time, 10 at a time. We need to blog. We need to use social media. We need to get groups of people together talking about what can we do with this coming generation of children to prevent them from going the way that so many millions of people have gone. Yes, we can do it. We can.
I believe we can as well, Roger, with people like you in the vanguard. And I want to thank you again for that spectacular introduction into your integrative care model. And now I want to invite everybody to please mark their calendars for Thursday, August 20th at 6:30 p.m. Central Time, when Roger will continue with the second installment of his presentation, which will key in on the implementation of his system into your practice. In the meantime, this is Danny Bobrow, as always, thanking you for your commitment to practice perfection. Goodbye, everybody.